Hello, everyone. Thank you for allowing us to present our research today. My name is Sammy Othman. I'm a Drexel medical student and research fellow at the University of Pennsylvania, discussing our project entitled Salvage of Total Ankle Arthroplasty. To start, there are no disclosures. Total ankle arthroplasty, otherwise known as TAA, is rising in prevalence. This has become the more popular option for patients requiring joint replacement due to improved biocompatibility, function, and pain scores in comparison to other more traditional options, namely arthrodesis, otherwise known as joint fusion. Failure of soft tissue coverage in this setting can result in infection, increased revision rates, arthrodesis, and ultimately amputation. The role of the plastic surgeon is to ensure vascularized coverage, help achieve prosthetic salvage and limb salvage. In this study, we performed a retrospective review of subjects requiring soft tissue reconstruction of total ankle arthroplasty. The reconstructive strategy was as follows: superficial, small wounds without exposed critical structures such as bone, tendon, and neurovascular bundles receive skin grafting or dermal wound matrices, while larger, more complex wounds receive some form of a flap. We then analyzed factors associated with salvage and failure defined as explantation. We identified 13 subjects as suitable for inclusion. 61% achieved salvage, while 38% achieved failure. The mean age for this cohort was 58 years with a mean BMI of 32. Nearly 15% of subjects had diabetes, 23% peripheral artery disease, and greater than 50% with a positive smoking history. The most common etiologies requiring TAA were degenerative joint disease and trauma, both at 46%. The mean defect size was 140 square centimeters, and nearly all subjects at 91% had a positive infection status. However, these factors were not correlated with salvage or failure. We did find significant differences, however, in the timings to procedural intervention. This included the time from the index orthopedic procedure to the index plastic surgery procedure, as well as the time from the initial wound diagnosis to the time of the index plastic surgery procedure. And these differences are highlighted in the table below in the red square. However, we found identical number of procedures across groups based on specialty, also in the table below. As you can see, various strategies were used successfully, from skin grafting to free flaps. One example of the free flap was the medial femoral condyle flap. As you can see in the x-ray on the left, one patient with a TAA is unable to achieve bony union. In the central pictures, you can see intraoperative photos of the MFC harvest, and on the right, you can see a well-healed bony union following application of the MFC. To discuss, we find that early intervention is essential for salvage. This helps vascularize the wound bed and wards off infection, and this is in line with previous literature that has shown improved outcomes for various prostheses across the body and increased chances of limb salvage following early intervention. Challenges in the setting of TAA include limited options in the distal leg. This is due to limited soft tissue, difficulty with the angiosome and blood supply of the distal third of the leg, and potential for infection. Thus, the goals in this setting are for early intervention, adequate wound bed and debridement to ensure the removal of infection, preserving the native soft tissue, and again achieving early coverage to prevent infection. In conclusion, salvage rates for complicated TAA are poor, as we note from our study. Multiple reconstructive options are available successfully, and early multidisciplinary intervention and soft tissue reconstruction is critical to optimize outcomes in the setting of TAA. Delays in diagnosis and definitive soft tissue intervention, namely consulting plastic surgery for the index procedure, are associated with decreased rates of successful TAA salvage. Thank you for allowing us to present our research today.